Hi, my name is Habtamu Gebresenbet. Today I like to talk about the original article written by Stephen Harnan, Robert Sicher, Susan Maslanka, Nicholas Joel, and Charles Hathaway. The topic of the article is human botulism immunoglobulin for the treatment of infant botulism. This article is published by the New England Journal of Medicine in 2006. Introduction and background information. What is botulism? Botulism is a rare but potentially life-threatening bacterial illness. Clostridium botulinum bacteria grows on the food and produce toxin that cause paralysis. Botulism poisoning is extremely rare but so dangerous that each case considered a public health emergency. Studies have studies have shown that there is a 35 to 65% of chance of death for the patients who are not treated immediately and effectively with botulism antitoxin. Most of the botulism cases reported each year come from the foods that are not canned properly at home. Botulism from the commercial canned food is rare, but the commercial canned chili products were identified as the source of botulism outbreak in 2000. Human botulism immunoglobulin, which is mostly known as by baby big. Human botulism immunoglobulin is which is neutralize the botulism toxin. This is an orphan drug that consists of human-derived anti-botulism toxin antibody type A and type B. The purpose of this article is evaluate this drug's safety and efficacy in the treatment of infant botulism, which is the intestinal toxemia form of human botulism. The general symptoms of this disease are nausea, vomiting, fatigue, dizziness, double vision, dry skin, dropping eyelids, difficult swallowing, slurred speech, muscle weakness, body ache, paralysis, and lack of fever. This figure explains enrollment, follow-up, and data analysis in the randomized controlled trials. As we see in the figure, a total of 180 patients were evaluated for eligibility, and out of 180, 129 patients were enrolled in the clinical trial. Of those, 122 participants as a laboratory confirmed infant botulism and could be evaluated for all outcome measures. And 63 patients received in the placebo immunoglobulin, and 59 patients received in the treatment group. They receive botulism immunoglobulin. Patient eligibility. They include all infants admitted to the hospital in California because of suspect botulism from February 24, 1992 to March 24, 1997. All infants were eligible for the trial if they had acute flaccid paralysis consistent with infant botulism and had been hospitalized for less than 3 days. A laboratory confirmed case of infant botulism identified in the patient's feces and enema specimen. Both the randomized trial and open-label study enrollment was based on the bedside clinical diagnosis. The, the project director or principal investigator would then transport the masked letter-coded study vial containing either BIGIV or placebo, written informed consent for enrollment from the parent. The study protocol was approved by the 62 Institutional Review Board. Patients in open-label study were eligible to receive BIGIV anytime up to 3 weeks after hospital admission. Out, Outcome measure. The primary efficacy outcome was the duration of hospitalization required. The secondary efficacy outcome includes the duration of intensive care, the duration of mechanical ventilation and tube feeding, the number of adverse events per patient, and the total charge for the hospital stay per patient. Statistical analysis. The outcome measures for the randomized trial were analyzed by the non-parametric Kolmogorov Smirnov test and by the t-test. Statistical analysis with the use of Stata software version 8 were based on the intention to treat population as initially assigned. The linear regression technique were used to adjust for the randomized difference between the placebo and the BIGIV groups. This is a baseline characteristic of infant in the randomized trial. As you see on the 63 patients receive placebo and 59 patients receive the treatment group. And the baseline characteristics of the two groups were similar, except that infants in the treatment group were older and weighed more than the infant in the control group. The proportion of patient with type A illness and the patient with type B illness in the two groups were almost similar. This table is explain the primary and secondary efficacy result of the randomized controlled trials of BIGIV treatment. On the very left side, you will see the outcome variables such as length of hospital stay, length of ICU stay, duration of mechanical ventilation, duration of tube or intravenous feeding, number of adverse events per patient, total hospital charge per patient. As compared with the control group, in the randomized trials, infant treatment with BIGIV had a reduction in the mean length of hospital stay. The primary efficacy outcome measured from 5.7 weeks to 6.6 weeks. BIGIV treatment also reduced the mean duration of intensive care by 3.2 weeks, the mean duration of mechanical ventilation by 2.6 weeks, the mean duration of tube or intravenous feeding by 6.4 weeks, and the mean hospital charge per patient by 88,600. There were no serious adverse events to BIGIV. So all of the p-value of all of those outcomes are less than 0.05. So it is statistically significant of the result. This table is explained the hospital stay and the hospital charge avoided by upper level treatment with the BIGIV within 7 days after the hospital admission. As you've seen on the table, the variables are the mean length of hospital stay, the mean length of hospital stay avoided, the total length of hospital stay avoided, the mean hospital charge, the mean hospital charge avoided, the total hospital charge avoided. BIGIV wasn't given on 366 patients treated within 7 days of hospital admission. The mean length of hospital stay was 2.2 weeks. BIGIV treatment given within 3 days of hospital admission shortened the mean length of hospital stay to 2 weeks, which was significantly shorter than the mean stay of 2.9 weeks when the treatment was given 4 to 7 days after the hospital admission. The mean hospital charge per patient for the 366 patients were $57,900, and the total of 20.3 years of hospital stay and 34.2 million in hospital charge were avoided through upper-level use of BIGIV. Patients in upper-level study had adverse events that were similar in nature and frequency to those randomized trial. This is a conclusion of the study. Treatment of infant botulism type A or type B with a BIGIV was safe and effective in shortening the length and the cost of hospital stay and the severity of illness. Treatment should be given as soon as possible after hospital admission, should not be delayed for confirmatory tests of phases or enema. Baby Big is available as a public service orphan drug in the United States. Here is a list of my references, and thank you for listening to me. You have a nice day. Thank you.